Welcome to this talk. Now, the other day we were thinking about vaccination, the possibility or the probability of a vaccine being developed for COVID-19. But it's not looking hopeful until the middle or the second half of 2021, unfortunately. So what would be really useful is if we had some therapeutics, some drugs we could use to treat COVID-19 infection when it comes along. And I've done a bit of an update on this. I think it was about just over a week ago now, but I think it's time to do another one because there's some interesting bits and bobs to bring to you. Now, part of the philosophy with drug development is it takes a long time to develop a new drug. There's all sorts of clinical trials it has to go through. It has to go through toxicology trials, then animal trials, then phase 1 trials on human beings, then phase 2 trials on larger numbers of human beings, and then phase 3 trials in a simulated real world situation to see if it works. And the whole thing just takes ages. But the thing is, we've got a lot of drugs already. So wouldn't it be great if we could find some drugs that we had already where we know the dose, where we know the safety profile, where we know the way to give it? If that could be used for COVID-19 infection, that would be brilliant. And way back in February, I heard some almost anecdotal reports from China that statins might be useful. And on the 24th of June, this was actually published in Cell Metabolism journal, which is a well-known biochemical journal. Now, just before I do that, statins are these drugs here. So this is what a mate of mine takes. He takes simvastatin. And they all end in statin, S-T-A-T-I-N. Now, I've actually been taking statins myself for years now, 5-6 years. And this is the one I take. I take a torvastatin. So you see it's the same. It still ends in statin. And there's various other drugs that end in statin. And that's why we call them statins, obviously. So they all end in statin, so we call them statins. Now, these drugs were originally developed for lowering cholesterol. So my low-density lipoprotein cholesterol, my LDL cholesterol was a bit high. Can't remember what it was now. I think it was about 7 or something like that. And these bring it down. So they lower harmful cholesterol, and at the same time they slightly raise the levels of protective high-density lipoproteins, the protective healthy cholesterol. And it's known from large-scale studies that people that take statins get less heart attacks and less strokes. And it was assumed that this was caused by the cholesterol-lowering effects. But now there's all sorts of debate about whether cholesterol is good, bad or indifferent, although there are clear correlations with arterial disease. But what is also become clear lately is that, and this was unintended, but statins are also anti-inflammatory. Interesting. So vitamin D is anti-inflammatory, dexamethasone is anti-inflammatory. So let's look at this study now. And bearing in mind that statins are anti-inflammatory, this becomes very interesting. So use of statins is associated with the reduced risk of mortality amongst individuals with COVID-19. This is published in Cell Metabolism, 24th of June. So a reputable scientific journal. Look it up for yourself, of course, by all means. Now, we know that statins are lipid-lowering agents. They're lipid-lowering therapeutics. They lower the amount of harmful low-density lipoprotein, LDL, in the blood. They lower that, and they increase the high-density lipoprotein a little bit as well. So, all good. But they're now known to have anti-inflammatory effects. And the first I heard about this, it must have been about 10, 12 years ago now. It was found that people who were admitted to hospital with pneumonia did better if they'd been on statins previously. Because the idea is that the statins, because they are anti-inflammatory, reduces the risk of the acute respiratory distress syndrome, ARDS. And that's the one where the alveoli fill up with inflammatory fluids that you probably remember we've talked about before. These air sacs that are supposed to be full of air fill up with inflammatory fluid, so the oxygen can't exchange and the carbon dioxide can't get back in. In other words, the lungs become too soggy because of these inflammatory effects, just in the same way your ankle becomes soggy when you sprain it and it becomes inflamed and it becomes swollen with inflammatory fluid. very similar fluid actually in a swollen ankle as in the alveoli. So these anti-inflammatory effects in pneumonia presumably were reducing this acute respiratory distress syndrome. And it could well be that the same mechanism is happening in COVID-19, because we know that the ARDS is a way that people with COVID-19 can die if they have severe acute respiratory distress syndrome. So we know that statins have this anti-inflammatory effect. So this study proposes it as an adjunct therapy for COVID-19. Adjunct means we would give it as well. Now, the reason I like this study is whenever we're giving a medicine, it's always a risk-benefit analysis. All medicines that are going to work have got possible side effects. All of them. There's risks with every single therapy, every drug. The only medicines that are completely safe to take, which aren't medicines, are homeopathic treatments. They are completely safe to give because they contain 1, 2, 3, 4 or even no molecules of the original substance. So they, by definition, they can have no side effects. Of course, by definition, they can have no pharmacodynamic effects either, but that's a separate debate. Well, it's not a debate, it's a separate fact. Anyway, they're perfect. So what I'm saying is all drugs have risks. All drugs have potential side effects. And it's always a balance. Well, okay, this person needs this drug. It's got this potential beneficial effect, but it's got this potential downside as well. What's the risk-benefit analysis? And the thing is with statins, I mean, I've been taking statins for, I don't know, what did I say, 6-7 years now, and I never had a side effect yet. And most people don't. A few people do. I'm not saying they're without side effects. All drugs have side effects. And a few people, a very small minority, have serious side effects. But, you know, there's millions of people around the world taking statins, and the vast majority of them do very well without side effects. So statins are, you can never say a drug is safe, but it's a pretty safe drug. The safety profile is well established through millions of people taking them. So pretty safe to give. So if I was in hospital and I was poorly with something, you know, I would like to carry on with my statins for most conditions because they're pretty safe to give. And it's got this anti-inflammatory effect. But the theory is completely useless without the practice. So this was a retrospective study. Now, immediately we see we're not in ideal territory here. Prospective studies are much better than retrospective studies. So if someone's pitched up after the event, collected a load of data and looked at it, that means they can't control for the variables. So it's not ideal, it's an observational study. But the results are interesting nonetheless. Now, there was 13,981 patients admitted to this hospital with COVID-19 in China. And the scientists from this cell metabolism people have crunched this data. Now, of that nearly 14,000, well over 1,000 were taking statins and carried on receiving statins in hospital. So this group received statins. Now, I know that number is much larger than that one, but of course the statistics can account for this. What that means in essence is this is the experimental group and this is the control group. So it's a good size number. These are good numbers. 28-day all-cause mortality. In other words, they let this run for 28 days and they said, okay, who's died? And in the statin group, 5.2% of the people had died. In those that received the statins, and those that did not receive the statins, 9.4% had died, and that gives us what we call a hazard ratio of 0.58. So what this means is the hazard ratio is, so if the hazard ratio is 1 to 1, that means the risks of dying are the same if we're talking about mortality. If it's 2, if the hazard ratio is 2, that means you're twice as likely to die. If it's 0.5, that means you're half as likely to die. So 0.58, we can see that these people are 58% less likely to die. No, it's 58, so they're actually 42% less likely to die. That's what it means. So the hazard ratio is 0.58. So that is quite a substantial reduction, 42% less likely to die. So that's quite good, hazard ratio 0.58. So this implies potential benefits of statin therapy in hospitalized subjects with COVID-19. It implies that. Does it prove that? Absolutely not. This is a retrospective observational study. But it implies it reasonably strongly. And this was interesting. There's no indications of increased risk using statins, as there was, for example, with hydroxychloroquine, where there was potential toxic effects. And as well as that, when they use statins in combination with drugs that lower blood pressure, the combination of statins and with the drugs that lower blood pressure, again, there was no increased risk. So again, quite promising here. But of course, there's many potential confounding factors. So what we have is the cause. That's the drug. And we have the effect. And the drug leads to the cure. Only it's not quite a cure, it's a reduction in mortality. And these confounding factors are anything that gets in the way of these things. So, for example, the lower mortality. So, here's the drug, and here's the lower mortality. Now, was it giving the statin that actually caused the lower mortality, or was it the confounding factors? That's what we don't know. So, for example, it's been postulated that the people that were taking statins had more access to medical care in the Chinese situation and were therefore more likely to be affluent, therefore more likely to be better nourished. Therefore, that's the thing that was lowering the mortality, rather than the fact that they were taking statins. So we don't know. So what we need is prospective studies. But in my view, this data is strong enough that if I was admitted to hospital personally with COVID-19 and severe disease, I would want to carry on with my statins. I think the evidence is strong enough for that. I would want to carry on with my statins. And certainly I believe that the evidence is strong enough to merit prospective studies. But of course we need a randomized, preferably double-blind controlled trial. Then we would know. But right now it looks like a pretty good guess to me. So, interesting one. Statins, dirt cheap, readily available, cost nothing, safe to give, could reduce mortality, could give you a hazard ratio of 0.58 as opposed to 1. Quite promising. Now, what do we know in therapeutics? Well, we did look at this Dexamethasone study which is reported, which reduces deaths by 1/3 in ventilated patients. Again, the hazard ratio there is 0.65. So that's actually 35, isn't it? Yeah, 35. So if a third would be 33. So it's basically by 1/3 reduction in death rate in ventilated patients. And the probability of that result arising by chance is very, very low. Reduced death by 1/5 in patients receiving oxygen therapy as well. So just a 21% reduction, a 20% reduction rather, in people that are receiving oxygen if they're giving dexamethasone. Interesting, dexamethasone is anti-inflammatory, vitamin D is anti-inflammatory, statins are anti-inflammatory. And we know it's the inflammatory side effects which are typically fatal in COVID-19 disease. So all this hangs together and makes a lot of sense. Now, the only other therapeutic we have at the moment is remdesivir. And remdesivir reduces the symptomatic phase from 15 days down to 11 days, but does not seem to reduce mortality. Whereas the dexamethasone definitely does. And it's highly likely, in my view, that the statins will as well. Let's hope someone gets a statin trial organised. Now, in the UK at the moment, we've got what we call the recovery trial. This is a randomised evaluation of COVID-19 therapy that's being done now in the UK. Do look it up for yourself. So, large randomised controlled trial of possible treatments for patients admitted to hospital with COVID-19. This is exactly what we want. We want these studies to be big. The bigger the numbers, the better. We need them to be randomised. We need them to be controlled. And it's randomised, meaning that who goes into the experimental group to get the drug and who goes into the control group to monitor and compare the effects of the drug. The people enter those groups on random allocation to eradicate human subjectivity. This is what we need. Now, 11,500 patients have been randomised in 175 NH hospitals in the UK. So this is excellent quality research. Now, what are they looking at? Well, the first therapy they're looking at is this one, lopinavir/ritonavir. Now, these are both antiviral drugs, and they're both currently used to treat human immunodeficiency virus, which of course causes AIDS, HIV. HIV is an RNA virus, just the same as COVID-19 is an RNA virus. So, again, we know these drugs, we know their doses, they're obtainable, we know their safety profiles. Kills one, well, doesn't kill, but suppresses one RNA virus, so will it do the same for another RNA virus? Pretty good guess. But the results aren't out yet. We don't know that one yet. Low dose dexamethasone, I think it was 6 milligrams a day, wasn't it? So we know that works. A third reduction of deaths in ventilated patients, 20% reduction in patients in hospital that require oxygen. No benefit in patients that do not require oxygen. So we know that works. So that one's a hopeful. The hope for that one. That one's a yes, that works. We know. Hydroxychloroquine has been stopped due to lack of efficacy. So the hydroxychloroquine wasn't working at all, so they stopped it. This was hydroxychloroquine. Stopped. Didn't work. Stopped it. Now, having said that, the hydroxychloroquine was not given with zinc, so there's still an unknown there. But the hydroxychloroquine in itself, the recovery trials dropped it. Azithromycin, commonly used antibiotic. And we know that COVID-19 is a viral infection, but there's reasons why that might work against this particular coronavirus, so that's been trialled at the moment. Don't know the results yet. That's a query. Don't know quite what's happening on that one. Now, don't pretend to be familiar with this drug. Toxilizumab. Don't pretend to be familiar with it. Anyway, it's an anti-inflammatory drug and it's given by injection at the moment. It's used for treating various inflammatory conditions at the moment. Never used it myself. But anyway, that's been trialled. Again, it's anti-inflammatory, so there you go. You know, all the other drugs that seem likely to work, the vitamin D, the dexamethasone, the statins, are all anti-inflammatory. So it kind of fits. And the other one is convalescent plasma. This is collected from donors who have recovered from COVID-19, contain antibodies against the SARS coronavirus type 2 virus. The data on this isn't out yet, but I'm pretty sure this one's going to work. I'm going to give that a very large tentative tick already. I think that one's going to work. Where people who are recovered donate their plasma with their antibodies in it to people that are acutely ill. It was a treatment for people that are acutely ill, because the antibodies that the convalescent patients have will have anti-COVID-19 viral properties, I firmly believe. Now, in India, there's a lot of fuss at the moment about this drug for Vipavir. Do look it up for yourself. Now, it's a drug for Vipavir. Again, you can see it's an antiviral. It ends in vir. So it is known to inhibit RNA synthesis in viruses. It's been promoted by this big Mumbai pharmaceutical company, and it's an approved drug. It's the approval of the Drug Controller General of India. So in other words, the drug control authorities in India have passed it for temporary emergency use. So it's authorised for temporary emergency use in India in certain circumstances. So what is favipiravir? It's approved in Japan for treating influenza. It's being tested in 18 clinical trials for COVID-19. It's based on phase 3 data, 2 positive outcomes. My levels of excitement are going down. The Indian press has been all over this for the past week, but it's based on pretty limited data at the moment. It's authorised in India for emergency restrictive use only for treatment of mild to moderate COVID-19 disease. Every patient must have signed informed consent before treatment initiated. The claims or the hopes are clinical improvement in up to 88% of COVID-19 patients. That's from these 2 preliminary positive results, but based on fairly small numbers of patients. It's hoped for a rapid reduction in viral load within 4 days, and it's given 2 tablets a day or 2 doses a day. BD is medical talk for twice a day. So it's given twice a day for 15 days. So that's favipiravir, which is a big Indian hopeful drug, but it's not being trialled in the UK. But those drugs that we did mention are being trialled in the recovery trial, and I have every faith in the quality of the research methodology in this recovery trial. So that's just a quick update on some interesting therapeutics. We'll just close with a few pictures today. Let's see, who should we look at? Here we go. So this is a doctor, and I'm not going to try and pronounce your name. I do apologise. Yeah, in fact, I can't even see you. I apologise again. There we go. That's much better. So anyway, you're watching Chennai in India, which is good news. And I've heard that you watch every day, so do appreciate you watching. Dr. Mad. No, I'm not going to try. I would just make a mess of it. My apologies. But we do appreciate you watching. Great to know people are watching around the world. This is Lucia, who watches in Portugal. So excellent to see people watching in Portugal, where there is a bit of a resurgence in cases in some places at the moment. This is Matt, who's in Utah, one of our many viewers from the United States, every one of whom is welcome. This is Dr. Johnny here, and this is his team from the Philippines. So these are doctors and nurses who've been keeping me a bit up to date from the Philippines. And I do hope you got the chance to watch that excellent interview with Dr. Ko a few days ago. So great to see you guys working very hard in the Philippines. And I know some of you do take time to watch the videos. And I've been told by Dr. Johnny that you are all, the entire clinical team, is taking vitamin D. Now, Johnny's a doctor. Quite a few of these ladies and gentlemen here are doctors and qualified nurses as well. And they all seem to think that vitamin D is worth taking. Now, in Johnny's clinical team, they've been treating COVID patients now for a couple of months. And so far, I'm delighted to say that none of his team have died. And only one of them has contracted the virus, and he had a minor illness, and they've all got their level of vitamin D topped up. Coincidence? I don't think so. And these doctors and nurses in the Philippines don't think so. So hope to hear more from these people shortly. Okay, that's us for now.